Welcome to our webinar on orthodontic retention and long-term stability featuring Dr. DeLuke, orthodontist and founder of the Ortho Coach, and Dr. Jackson, orthodontist and founder of Retainers for Life. And today they're going to delve into the innovative strategies for maintaining phase one results using clear upper and lower Essex type retainers, leveraging advancements like 3D printing and proactive monitoring. Dr. DeLuke is going to share some of his insights in his journey in orthodontics, emphasizing early interceptive treatments and their impact on the airway health. This webinar is going to challenge traditional practices by advocating for holistic orthodontic care that considers broader health implications. So join us today as we explore practical strategies to optimize your patient outcomes and enhance your practice's efficiencies. Over to you guys.
Thank you, Lorraine. Super excited to be here with Dr. DeLuke. Again, doing a webinar talking about all things interceptive treatment, retainers, and airway. So many of our audience members already know Dr. DeLuke, but if you haven't had an experience listening to him or his podcast, you can find on YouTube and on Apple iTunes, I believe, as well. Please go check that out. There's also a webinar that was recorded last year with Lorraine, where Dr. DeLuke talks a little bit about his journey and what led him into full-time coaching. So welcome, Dr. DeLuke.
Thank you so much, Amy. I really appreciate it. I'll just start by saying I love working with you and your Retainers for Life team. You guys are awesome and have made it very easy for me now. My goodness, I think it was it 2021? So 3 years ago that we started working together. So it's been great. So always a pleasure to speak with you guys.
Well, it's great to have you back again. So we'll just jump right into it. I'd like to know a little bit about your treatment philosophy, how that evolved with time. What do you think are the advantages of expanding during interceptive treatment, and how that might affect the airway?
So this is something I get asked about a lot. And just for a background, in the episode you referenced with Lorraine, I went in, she and I had a great conversation in detail, more kind of about my journey and how I got to the point where I'm teaching and coaching full time now. I have the podcast, as you referenced. I teach over at NSU in Fort Lauderdale and teach the residents there as an assistant clinical professor. So it's been a journey for me. So I spent essentially the first half of my career, essentially 20 years in private practice, started my own practice from scratch right out of my residency at UConn, built it up from nothing, built it into a big successful practice, and then decided that it was something I wanted to do for the second half of my career, to devote more time and energy to the teaching side of things and be able to take a lot of the things I learned, which we're going to talk about today, as you just referenced, with early treatment and airway and the things that I just figured out by doing it. I just had an episode on the podcast. I had Dr. Tom Pitts on, and he said something I loved, which is essentially that our knowledge sometimes gets in the way of our imagination. And I just loved when he said that, because you look at great creators. I mean, someone like Disney comes to mind, right? They use their imagination too. I mean, they go off of science, or in their particular case, whether it's the development side of things or whatever. There's certain things they have to abide by, but then they have an imagination to say, we're going to do this differently. And as I was practicing on my own, I think that's one of the interesting things about being a solo doc. You're forced to be imaginative. It's only you. You can't turn to another colleague and they can say, oh, hey, you could do this. I mean, you have to figure things out. And so I was a big believer in early treatment when I first came out and started practicing. I really wasn't trained in it, as many of us aren't, but I really didn't feel good about looking at these really narrow arches and constricted arch forms in these young, talking like 7-year-old kids that would come in, maybe even 6. And I would look, and it just, something didn't sit right with me with what most of us are taught as orthodontists, which is you just start pulling teeth on these kids. And something in me just felt, I've always really, really focused on etiological driven treatment that focuses on treating the cause, not just symptom-based treatment. And a lot of that is something Peter Attia, who a lot of people have read his book Outlive or know of his podcast, but he talks a lot about medicine 2.0 and medicine 3.0. Medicine 1.0 being like Hippocrates and bloodletting and not really trying to figure it out on the run. And then 2.0 being kind of what we're in now still, which is this era of we try to just treat disease, right? We just try to treat it instead of what he proposes as medicine 3.0, which is a more proactive approach to prevent disease. So taking that to dentistry and specifically orthodontics, I feel like we're kind of stuck in that ortho 2.0, right? Where we're just trying to straighten teeth. And we are very good tooth straighteners. And we go to school for an extra few years to be excellent at straightening teeth. But one thing that's missing in our education by and large, and this isn't a 100% clearly, but for the majority of school ortho residency programs out there, we're not treating young kiddos, like many people under 10 really at all. And we're not doing early treatment with a proactive mentality, right? It's kind of reactive. Like they have a crossbite, let's fix the crossbite. So we don't look at these kiddos that come in at like 6 or 7 with no crossbite maybe, and narrow arches, steep curve of Wilson in the lower arch, insufficient tongue space, maybe retrusive lips, looking at their face. Maybe they have allergic shiners, right? Maybe they've got an allergy problem. Maybe they have a breathing problem. Maybe they are mouth breathers. They have chapped lips, what I call chapped gums, which is like that thick hyperplastic gingiva in the anterior sextant. Start asking questions like in a pediatric sleep questionnaire of what is their sleep, what are their sleep habits and their sleep hygiene look like? What's their behavioral temperament like? And we'll expound upon these things as we go today and talk about why that's important. But I feel that we really need to start to teach and I teach the residents I teach, this is the sort of way you want to approach your care, not just can the teeth fit, right? Like looking at this 6, 7-year-old kid and going, oh, well, maybe I've got enough space and maybe with some good growth, we'll kind of be able to do this. And we put them in these recall observation pools and what we call watchful waiting. And certainly that's appropriate for some kids, but for some it's not. And our job is to determine which those are. So back to your initial question, I just started saying, well, I don't feel good about just treating the symptom, which is the symptom is the crowded teeth. The teeth are the symptom. They're not the cause. And I said, well, what can I do? So I was still teaching. I was teaching part-time at UConn at that point. I was driving back and forth from my practice in upstate New York. And at that point, it was kind of pre-internet, PubMed, accessible to everybody type. I mean, the internet was around, but we weren't able to do these queries and searches from our home computers like we can now. So I would go back and basically just go to the library and pull books and journals and just start to read about it. I started to realize we have been expanding early for 100, at that point, 100 years. Now it's 120 years. This has been a thing for a long time. We've also known about airway for that period of time as well. And one of the quotes I love is Engel in Edward Engel, founder, kind of founding father of our profession in 1907, said that of all the causes of malocclusion, mouth breathing is the most potent, constant, and most varied in its results. 1907. Like we've known that this is a problem, yet we continue to overlook it and just be reactive in sort of that orthodontics 2.0 and just say, well, I can't do anything about that, right? I'm the orthodontist. I can treat the teeth. So I just started expanding these patients and growing their arches. And from there, it just evolved. And I just started seeing changes in them that I honestly couldn't believe what I was saying. So that's how I got into that concept. And at that point, I had no concept of airway. I hadn't learned any of that in my residency. I wasn't looking at mouth breathing. I had no idea. I didn't have a cone beam. I didn't get that until 2014. So I really was just simply looking at it initially as something's just not right with treating the symptom of the crowding. I need to do something more than that.
I love it. And I think I love the idea of looking past the white things, right? Looking past the teeth and then being creative about solutions to help our patients.
Yeah.
It's not a one size fits all. And I think part of the frustration and what's been hard for our industry is we haven't been trained up on any of this in residency, or it's very rare to be trained up on any of this in residency. And we've been traditionally trained on there's one way. There's this one way. There might be a couple of different appliances to use, but there's
techniques
this
are different.
one way.
Yep. One philosophy.
Exactly.
Yeah. Right.
Exactly. So you have kind of a unique, and I feel like you've been through an expansion journey in your own practice.
That's well said. Yeah.
So I'd love to kind of know where you land right now on expansion therapy.
Mhm.
And you're welcome to talk about interceptive, early, or adult therapy.
Mhm.
I will be honest, I'm kind of on my own adult custom MARPE journey myself,
Mm-hmm.
just really due to the demand of a lot of really amazing airway friendly orthodontic practices and general dental practices here in San Antonio. But I'd love to hear a little bit about that journey from you.
So the airway side, just to give everyone a background for those who aren't aware or haven't heard some of my content on this, the reason airway is important, and the studies in the medical literature bear this out. David Gozal has done a bunch, Karen Bonnick, talking about the psychological impact and the neurocognitive deficits that can result from people breathing through their mouth and or snoring. And even light mouth breathing at night has been shown to affect development of gray matter in a developing young child. So this is real. This isn't just about, oh, well, you have a theory that we should pull teeth or shouldn't pull teeth. This is, what is the responsibility of the orthodontist and or dentist to recognize these issues and then address them? And that's a huge debate in our profession right now. Like gloves off, like it's a big debate. I am encouraged. A resident told me yesterday when I was teaching that I haven't seen it yet. The current edition of the AJODO does have many airway-centered articles in it, so I'm actually really anxious to take a look at that and start and hoping that we're heading more in that direction to push that envelope, because a lot of that sadly has come out of the medical literature and we haven't done enough in the orthodontic arena. But the reason it's important to see this is we might see a kid who comes in, like I said, that one young patient, 6 years old, 7 years old, with the crowding. But if that patient isn't sleeping or breathing properly, there's way more going on than just crooked teeth and narrow arches. And I certainly wasn't taught. I'm not at all knocking my program. I had amazing training. I mean, I was trained by Charlie Burstone and Robbie Nanda and, Flavio Uribe, great people. I would never be the orthodontist I was able to be and am able to be to teach my residents if it weren't for those people. That being said, we just didn't get into the air. As you said, it's a philosophical difference. It's not the same approach. So I started learning about this on that journey that you referenced. And as I was learning more about, because I was seeing, and it was so crazy, Amy, because it started happening. And I always was big on like analyzing my results. So I wouldn't just finish a case and just, that was the end of it. I would always sit down and look at the pre and post treatment records and review the letter I was sending to the primary care dentist and really look at what I did in that case. I started to notice these cases and these patients, especially when I was taking cone beams, their airway looked completely different after treatment. And I, again, wasn't doing this thinking I would have an impact on that. So I started talking to the parents, and some parents would just say to me, "Hey, Dr. Mike, you think it's a coincidence that like she doesn't snore anymore ever since we did this?" And, at that point, I literally was saying, well, I'm not really sure. Like it could be. I know expansion can help, minimize that. I knew that, that if you expand, you can help increase the patency of the nasal passageway. So I was like, it certainly makes sense. And then I started hearing it more and more. And then I started seeing cases where patient had adenoids that were a little enlarged pre-treatment, not enough to warrant surgery. And a year later, post-treatment, the adenoids were, shrunk to almost nothing. And I was saying something is going on here. Tongue postures were changing. Oropharyngeal airway was changing. So I really started to dive deeper down that rabbit hole and say, there's something more here. And that's when I got more interested in asking the parents of patients more questions about how their child was sleeping. So again, this kid comes in with crowding. We're not really taught, like, start asking them questions about how the kid sleeps, right? Or how the child breathes.
Right.
I started to do that. And I started to go, wait a minute, there's a connection here between these kids that are really narrow and really crowded and how they sleep and breathe. And then I started realizing, wait a minute, there are a lot of data out there to substantiate that there's higher incidence of ADHD. These kids have nocturnal enuresis that is persistent, and all of these other things that go well beyond the white things, as you said, in the teeth. And so this is that journey that I was on. And then I was the cleft craniofacial orthodontist on a team in my area. And I started picking the brains of the ENT and just saying, hey, look at this 3D. What do you think? And they started saying, oh, completely. If you don't have enough tongue space, or if you don't, you're impacting it. So it all just evolved from there. And we can get into later kind of the way I evolved in the treatment side. Again, not even talking about that, just the philosophical approach to this. I then started to really focus my practice on a lot of that. And people will say, I think one thing that's important to explain, I'm not saying that expansion cures obstructive sleep apnea, right? I'm not saying I treat obstructive sleep apnea or sleep disordered breathing. I'm not saying that you can solve it in every patient by expansion. I'm not saying every patient needs expansion. What I'm saying is when you take the time, when you have the knowledge, and then you take the time to diagnose the etiology of these cases, and you find the patient that does suffer from these narrow constricted arch forms, as the orthodontist, you go in and expand these arch forms and normalize them, which is our responsibility anyway in treating malocclusion. And many times you will see amazing resolution of the airway problems. That being said, part of this is recognizing in the initial records, do they have excessive lymphoid tissue hypertrophy? Do they have, are their nasal turbinates swollen and inflamed and hypertrophy to the point that they need to see the allergist? Again, those allergic shiners under the eyes, Denny Morgan lines, all of the things you start to, allergic crease in the nose, all the things you start to recognize, refer them to your medical colleagues for any definitive treatment on their end. And then you go in and normalize the intraoral side, which is our wheelhouse, and you have a different kid on your hands a year later. And I'm not overstating that. I mean, I had many patients, many parents of patients literally in tears. I've had multiple people on my podcast report the same exact story of parents in their office breaking down in tears saying, "You changed my kid's life. We didn't know what was wrong with him. They were putting him on ADHD medication. The teachers thought he couldn't learn and was slow." I mean, like, it was out of control. All of a sudden, they're like, yeah, they were 1 grade behind in reading. Now they were 3 grades behind in reading. Now they're 1 grade level above. I mean, this is the sort of thing I was hearing time and time again. And it really just kind of fueled a passion in me and a fire in me to want to get this message out.
Whole different purpose to being an oral health care provider, right?
Yeah.
I mean, it just is. I've had the same experience in my office, and I would say in the beginning it was accidental, right?
Same. Yeah.
I was treating the things that I was seeing from a traditional lens of an orthodontist, but it was having these whole health benefits to the patient on the other side. So, is it your belief that, and I like to use the term sleep disordered breathing, is it your belief that sleep disordered breathing is multifactorial, and what we can do as orthodontists is one piece of the puzzle to help or improve one factor that might be negatively affecting the patient?
So glad you asked that. And if I get too far off on a tangent here, feel free to cut me off, because this is an area that I just love talking about because it is so misunderstood. Obstructive sleep apnea, we'll call it OSA, right? And sleep disordered breathing, or SDB, or even the ADA calls it sleep related breathing disorders, SRBDs. So there's kind of all these names that we call them. I think they call that SRBDs are snoring, upper airway resistance syndrome, and obstructive sleep apnea are part of that umbrella. But the big distinction here is OSA, and this is one of the big problems I've been very open and vocal about I have with the 2019 AAO white paper. There's a lot of great information in there, and there's a lot of information that we can learn and implement in our practices. That being said, I think one critical mistake is they focused on OSA and obstructive sleep apnea alone, and all their recommendations come down to OSA. Well, when you dig deeper into it, Christian Gimeno, who helped set the scales, he's a legend in the sleep arena, kind of the godfather or grandfather of sleep medicine out of Stanford. When he built these scales, one of the things he's passed now, but one of the things people cite is, he said, as one of his regrets was kind of putting these parameters of the AHI scale on things. And so when they developed the AHI scale for children, so for adults, they ran a study. It wasn't a huge study. I think it was mostly Caucasian men that they did it on, to get the data of the parameters of the apnea hypopnea index, right? And so what they essentially did with the kids is they took those adult levels, they extrapolated them backward and just took essentially a third. So for the kids, it's like, okay, if you have an AHI, an incidence or a 1 count on the AHI scale is an episode of apnea or hypopnea, or anapnea or hypopnea, that lasts for greater than 10 seconds. Well, the problem with that is kiddos have a much more active sympathetic nervous system. So they rarely get these incidents of apnea hypopnea for greater than 10 seconds. So they can go for a sleep study and come back totally normal. And especially if they're not checking for RERAs and with the movement issues and activity, body activity and mobility, they're literally just kind of basing this on OSA, which is again what the AAO white paper focuses on. You're completely potentially missing a major problem with this child's breathing. And as I said, the studies in the medical literature show that even just light mouth breathing into light snoring can have neurocognitive defects and defects in the cortical matter and in the development of the brain. So we need to look at this a little differently. And so I don't rely on an OSA scale or send every patient for a sleep study. And number one, it's not feasible for a lot of patients. It's not covered maybe by insurance. Again, I would defer to the physician. They can't always get in some places where they don't have access to these. Even if they do, they're backed up like 6 months. And the data, not every sleep study is the same. Every sleep lab has a little different protocol. People are busy. Sometimes they're single parents and they got a couple kids and they can't be, there's just a lot of logistical challenges. So I started initially going to my pediatrician colleagues and saying, hey, maybe we should get a sleep study. And the pediatrician's like, why? I'm not ordering that. So I kind of was in this position where I'm like, well, I can either let this kid suffer or I can do my part, again, not treating the OSA, but do my part, which is normalize the intraoral and refer them to the medical specialist if I noticed they had lymphoid tissue hypertrophy or turbinate hypertrophy, signs of allergy. So that's what I started doing. And so I literally would just I didn't base this off of OSA because sleep-related breathing disorders or sleep-disordered breathing is really any sort of sleep breathing issue that these patients have. It's the incidence of sleep-related breathing disorders or sleep-disordered breathing is like 12 to 14%, I think, is the numbers that the American Academy of Otolaryngology Head and Neck Surgery cite. And they say 10% of kids snore regularly. So I think it's 12 to 14% they say have sleep disordered breathing, and 10 snore regularly. Well, that doesn't mean that they have obstructive sleep apnea, right? There's actually far fewer than that. I think it's like 1 to 5% that they say can suffer from OSA. So there's this huge number of kids, and you say, well, Mike, that's only 5 to 10%. Well, multiply that times millions of kids. That's a huge number that we're missing. And so I think it's a big, and I hope that explanation made sense because it's a bit nuanced. But the key is when the kids feel that they're not breathing and that stimulus goes to the brain, they, instead of letting it go greater than 10 seconds and then kind of trying to catch their breath, they squirm and move, which is why in a lot of these kids, they're restless sleepers. They wet the bed. That has to also do with vasopressin levels, but they're turning upside down. They're flipping. They wake up like a zombie, right? They go through periods of hyperactivity during the day and exhaustion during the day. They crash. They're often said that they have ADHD or they're hyper in school. So a lot of that is these kids are sleep deprived, but you can send them for a sleep study and they might show us a 0 or a 1, right? I barely even register on it. The last thing I'll mention on that is that's where I have a big problem with a lot of the data that gets put out there because a lot of the literature focuses on OSA as well. And what happens is you get these studies that will say, oh, we took this cohort here and it gave them expansion and this 12-year-old group. And then we took this other group and we didn't expand them. And they both started with the same AHI of like 1.5 or 2 or whatever. And 4 years later, there's no difference. And the thing is you're using an inappropriate, non-specific diagnostic tool, which really doesn't tell you anything of whether or not that child is suffering from sleep disordered breathing. And the ADA did quite a good job on that, I feel. They actually said that all dentists should screen for, again, they call them sleep-related breathing disorders in all children. Yet we're not teaching this in our residencies. So the ADA put that in 2017. Put the guidelines out with that you should be screening for this in all children and that you should then intervene through medical and or dental evidence-based treatment. Well, isn't expansion evidence-based treatment in a patient who's narrow? I mean, I think that's hard to refute, right? And then to work towards developing an optimal physiologic airway and ideal breathing pattern. I don't see why this is so controversial. Yet so many people in our profession are so steadfastly against everything I just said that a lot of times on my show, on my podcast, I talk to people. I'm like, why are people so, I just, for the life of me, and Tom Pitts, again, to reference him, he said, he's like, if you don't know better, it's hard to do better. It's just kind of easy. If you never learned it, if you never are comfortable with it. And I almost think that's the point that I've gotten to, is I think it's hard to change, and it's easy to become dogmatic, and it's easy to look at the way you've always done things and think it's the way it should be done. And it's hard to look at yourself and say, hey, I treated thousands of patients maybe in a way that wasn't ideal, and have the humility to say, I know that now, and I'm not bad because I did that. It doesn't make me a bad orthodontist. It just means everything in medicine in that sense evolves and should. So
I could have done better for those patients, but it's hard to say that, right?
Yeah.
I mean, I will say, a lot of orthodontists, as do I, and yes, the majority of us have very strong opinions. But they're good people that want to help patients and
Agreed.
care about patients. So along those lines, I really believe that the screening process or the new patient exam has to evolve. And I would go so far as to say, I think your vision, honestly, for the future is orthodontics 3.0, where we look at the patient as whole health.
Yeah.
And the whole health of the patient matters to us. And then we build a treatment plan or a map for that patient based on getting them healthier. And so what, and again, I know this has evolved for you through the years, but what would your exam with an intercepted patient look like right now? What is your screening process? And the more detailed you can be, I think the more helpful for the audience. And by detailed, I mean, are you sending out a certain sleep questionnaire to them via email or in the mail, so it's filled out before they even come in? Are you asking soft questions about sleep instead of, what's actually listed on the questionnaire? How are you combing through the information that the patient is bringing to you in a short amount of time to figure out what is best for the patient?
I love that. And I do agree that the whole patient approach is really where we need to get as orthodontists. It's above my pay grade to know exactly how we're going to get there. All I can do is keep trying to put this message out. And I so appreciate you talking about this, having me on to talk about this, because the more we can get this, and a lot of what I'm trying to do with my podcast is just get that message out. And I think that's where we need to start. That being said, we have a lot of work to do. So to answer your question, yes, I feel you need some sort of screening questionnaire on airway leading in. There's the Ferris 5, Ferris 6. There's the, is it 6 or 5? John, like Ferris 5, right? Ferris 6?
Ferris 5, yeah.
Yeah, Ferris 5. So there's the Ferris 5. There's the PSQ, which I think is kind of the most commonly used. And I think the important thing is people use one they're comfortable with what they're actually asking, right? If you're asking something that's a little more esoteric or random that you're really not confident in, don't ask that question, because the parents are going to ask you what you're talking about. And if it's a Mallampati score and you don't know what that is, you don't want that in a questionnaire. So make sure you understand. So the sleep PSQ is a pediatric sleep questionnaire. It's pretty generic. You could even have your own version of that. I kind of had my own version of that I used, where we had certain questions we would ask specifically. And in my lectures, I go into what those were, but that's a good basis for people to start, right? Then you would use that, and you can give it to them ahead of time, right? A lot of people, we gave all of our paperwork ahead of time with digitally, so they had it. But as we all know, they don't all pay attention to it. They don't all fill it out. Sometimes it's dad the night before, last minute, and mom brings the patient and she's like, oh, dad did that last night. He doesn't know what he's talking about. So, we all have that happen. So you have to follow up on it in the office. You can't just look through quickly and make a cursory glance and be like, oh, this patient doesn't have anything. We're fine. So my protocols in the new patient exam and in the consultation, I am big on this. And I actually teach this in my courses and to the residents. I literally teach them how I conduct a consult. And the brief version of that is you need to have really good diagnostic records, ideally with a cone beam, a low dose cone beam. The whole argument that CBCT is more radiation isn't valid anymore. There are machines that deliver less radiation than a 2D Panorex. So, not every machine does, but there are machines that do. So you can certainly do 3D for lower radiation than 2D. You get, way more diagnostic information. You can't even compare. So good imaging, ideally 3D. good picture, intraoral and extraoral pictures, and then you need to do a clinical examination. I have no problem with same-day starts. Love a same-day start if it works for you and for the family. But it's not a race to get this patient in braces. It's not a race to get to the next patient and overlook this new patient you have in your chair. Do our jobs, right?
Yeah.
We are trained. What separates us from our pediatric dental and our general practitioner colleagues? Our training in diagnostics and our mechanics in treatment. Yet we're like trying to dumb down both of those so much that we get to the point. And some of that's good, right? I always push the envelope of efficiency and streamlining and trying to make things go faster and better. And I mean, I think I drove my team nuts with that because I'm always pushing that envelope. That being said, you can't abandon certain fundamental principles of what we do. If you have a treatment coordinator, this is my opinion. I'm not, passing judgment on people who do it because they're free to practice the way they want. But in my opinion, if you have a treatment coordinator handling your diagnostics and you're not doing a clinical examination on your patient, you're not doing your job. And I would go as far as to say there's malpractice implications there. The least you can do is examine your patient, right? So what does that look like? You look at the face. And that is a big thing we don't teach. If you go to a residency and you talk to the residents and you sit a patient down, what is the first, where do they start with the new patient? They sit them back and they look in their mouth. It's the first thing they do. They don't look at the white things. And what's the first thing they go for? What molar class are they, right? What we're taught to do. We're taught to look at teeth. That's what I did. And I teach them, no, you've got to look at the face first. The face will tell you, excuse me, the face will tell you so much about this patient's growth, their development. The eyes are the key to the soul. You can see in these eyes if this patient, I show pictures all day of some of these 6, 7, 8-year-olds that walk in and they've got dark circles under their eyes and they're tired. I mean, that's not what a young kid like that should look like. Either there's issues in the home that's causing them to not sleep, or they have a sleep disordered breathing issue that they're not sleeping soundly. So when you see those things and you see, say, your questionnaire that says everything's fine, then you got to dig deeper. If the questionnaire says everything's fine and you don't see any signs of that, and you look intraorally and they have broad arches, and you look at their 3D and their nasal passageways have nice patency, and I teach a tour of the airway that I take in a 3D. I literally just went through it yesterday with the residents. You go through this 3D tour, you go up through the nose and then look at the sinuses and down through the nasopharynx and the oropharynx. Really easy, really simple. You're looking at the different sagittal, axial, and coronal slices, and you just kind of taking them with the parents. You just take them on a little tour. And then if you see things like turbinate hypertrophy, hey, mom, does Johnny have any like stuffiness chronically or allergies or have trouble breathing through his nose? Yeah, now that you mention it, like, yeah, he kind of always is stuffy. We just thought he's a stuffy kid, right? Oh, well, maybe this is a patient. Even if you don't need to do ortho, send him to your allergist colleague. Maybe Johnny's suffering breathing that way. I mean, I, as an allergy sufferer who had 2 sinus surgeries not long after I finished my ortho residency, I get it. Like this can get real if allergies get, and I'm still going through allergy shots and immunotherapy for my allergies. I mean, allergies can be a significant burden. So I had so many patients that just sending them to the allergist and having them diagnose their allergies. And then they realize, oh my gosh, Dr. Mike, like we didn't realize, he's allergic to this. And we have a lot of this in our home. And we just had to do this. And now he's like so much better. And you're, like you said, the whole patient, like this isn't hard. And so those steps, I haven't even talked about the teeth yet. I haven't even talked about the teeth to them. I'm just getting a feel for the patient. We ask, have they seen the ENT for anything? Have they had their any tonsils and adenoid removal? If so, how did it go? We ask if they've seen an allergist. Do they have any allergies? You have to ask those questions. But again, sometimes people just go through those histories. No. They're doing it late at night. They're in between, calls at work, and they just don't focus on it. So you've got to then look at the patient and ask the appropriate follow-up questions in the room with the patient. And that's where you get your foundation for starting to make some of these clinical decisions.
We are the professionals, the healthcare professionals, and these parents are busy. They are busy.
Right.
Sometimes a lot of the things that's happening with their kids goes right over their head.
Mm-hmm.
So I think it's very important to do a thorough exam and also ask questions that might trigger something in their mind. Oh, that one
Yes.
time when we were on vacation in a room together. Yes, I did
Yes.
notice X, Y, and Z. So,
And we tend to kind of almost like normalize the things our kids do and ourselves. It's human nature,
yeah,
right? Like
true.
it's like, oh, I just thought he was a stuffy kid.
He
Like
always,
you don't really think about it, right? Like, oh,
Yeah.
he's always got a little cough. He's always kind of,
Yeah.
but we just thought that's who he is. And that's just how we all are. So you're so right. That's such a good point, is we just kind of normalize that. Like it's nothing. And then when you call attention to it, and then the other side I've had is where you call attention to it and you get the look from the parents, and they give you the look of, how the heck did you know that? And some will say it, and they're like, how did you know by looking at the teeth? And I'm like, well, that's why we look at more than the teeth, because the teeth are just part of it. And they're like, but I've been telling the pediatrician for X number of years, or I knew, maternal instinct is real. And you'll get some moms who are like, I knew something was wrong and nobody would listen to me. And this proves it. And then you get that kid to the ENT and or allergist, and you go in and help them grow. And those are the kids whose lives you completely change. I mean, completely change. I had a mom on my podcast in the fall who, again, coincidentally, I literally just went through this case with the residents yesterday. But I mean, my dad is a certified registered nurse anesthetist. Mom's a CPA, super intelligent people. They brought their daughter into me because she was 6. She had upper left 1 was a little protrusive, and they just didn't want any incidents of trauma. And the pediatric dentist was like, yeah, you don't really need to go to the orthodontist yet, but if you really want to. Turns out, to answer to your question, we had asked the appropriate questions leading into the exam with the questionnaire and the questions, and then following up clinically, because she presented with allergic shiners and tired eyes, narrow arches, and insufficient tongue space, and mild to moderately enlarged adenoids, and narrow nasal passageways. So I started asking mom the questions. Mom literally, when she recounts this in the podcast episode, was just like, how are you knowing this? And I then come to find out they hadn't disclosed it fully on the paperwork, that this kid was suffocating at night. Dad was up with her at night, holding her head up so this kid could breathe. And it turns out, and mom tells the story, 3 to 4 months into treatment with my archwire expansion, she was off the singular that they put her on. They had to go listen to her and put their ear up to her nose and mouth, because they didn't know if she was alive because she was breathing so quietly.
Wow.
Yeah. And that's what I tell people. This is real stuff. And again, I'm not treating her airway issue in that sense, but I just treated the etiology of some of the problems that were causing her to not be able to breathe through her nose as well, and forcing her to mouth breathe. And I mean, literally, I showed the slide yesterday to the residents, the before and after of her adenoids. I mean, they went from mild to moderately overgrown, not enough to do surgery. The ENT put her on singular as a hope for that, to a year later, off the meds for, at that point, 9 to 12 months. And the adenoids were like essentially non-existent. And and you have a different kid. Mom's on video saying, I mean, she did better in school and she started liking going to school. I mean, and then the other part of that is mom talked about the self-confidence you give these kids. Not only because they're thriving now as humans, right? They're sleep. I mean, think of any of us on them. Get a few nights in a row of disrupted sleep. It can be tough, let alone you never can catch up. And then you add in, these kids don't always look, when those narrow arches and crowded teeth, like it's not the nicest, most aesthetic look, even if you're only 7, 8 years old. I didn't expect this part. You were talking before about things that you just kind of stumbled on, and we do that so often. All of a sudden, these kids are just shining. And the parents like, this is a different human. Like, my kid's a different kid. And why is our profession, why is it so taboo to talk about? Let's even take the airway stuff out. Like, why is it wrong to make 8-year-olds look good? Like, I'm not saying every 8-year-old tooth needs to be straightened at all, but we talk about like, no, you can't do anything like that until they're in the teen years. Well, kids are tough. Kids are tough. And I saw kids that you get the story, and maybe after treatment or even during treatment sometimes, where mom's like, she never told me that she was being bullied at school. But I didn't know why she didn't want to go to school, because she's a really smart kid and teachers like her, but she didn't want to go to school. Well, all of a sudden she started to say, Mom, so-and-so doesn't tease me anymore about my teeth. And as a parent, that really gets you. Even if you're not a parent, as a human, you have to be like, your heart just breaks. And so I think we need to kind of finalize my answer to your question. And I didn't do this. And I think it's actually, now that I'm saying it, continuing to learn, I'm going to start to incorporate this more into the protocols when I teach the residents, is start to ask about psychosocial impacts of their teeth, even for the younger kids, and see if they're getting teased or bullied. Because I would obviously, if I was told they were, if I noticed a severe malocclusion, I would ask that question, but it wasn't standard for me. And looking at it, I think probably it should have been.
Absolutely. I think that's, again, something that we overlook. We're busy, right? We have systems, and that's
Right.
not part of our traditional system. But
Right.
man, what an impact that makes to not only the individual, but as you're telling the story, I'm thinking about the positive impacts that that's making for the entire family.
Great point.
You are a parent, you know how gut-wrenching it is when something's not right with your child.
Mm-hmm.
And even if they're not communicating exactly what's happening, you feel it, you sense it, and you carry it with you. And so, just to impact not only the health of a child, but their entire family is something within, again, we're positively impacting the etiology that an orthodontist can affect, which is not everything.
Nope.
And we can't cure sleep disordered breathing, but we are one piece of the puzzle, and we should be looking for what puzzle pieces is not fitting or is off track. So
completely. And I agree. We can't cure it. As you alluded to before, it is multifactorial on the sleep and airway side of things. Expanding I had some patients, it wasn't a ton, but there were some patients where I developed the arches, broadened everything out, got them good tongue space, good expansion, good, no more high palatal vault. Everything was nice. And you look at the post-treatment CBCT, and they have nasal passageway patency and no lymphoid tissue and good pharyngeal airway space. And the kid is still not breathing right. And again, that's when you're like, okay, we really need a sleep physician involved, and we need to take this to the next level. It was so few and far between. I mean, literally count on one hand, but I can actually think the two I can think of that had happened where I can picture them. But there's a lot more going on. But my approach was always, and the way I would explain it to the parents is, let's normalize as much as we can first, because I can see this is clearly a problem, and studies and data support the fact that patients with narrower arches, less tongue space, high vaulted palates, all have a higher incidence of sleep-related breathing disorders, obstructive sleep apnea later in life. We know that. So if I can normalize that now, then that's a bunch of variables we take out of play. And if I can get you to the appropriate physician who can address anything going on in the nasal pharyngeal airway, then why would we not do that? And one more point on the AAO, they actually said we should go to our medical colleagues and defer to them regarding how to treat this patient, not the medical treatment. I'm not talking about taking tonsils and adenoids out, but that we should go to the pediatricians and let the pediatricians be the quarterback of the orthodontic care. And I'm like, when is the last pediatrician you met? And this is not a knock on pediatricians. I mean, I don't do their job or pretend to know their job, but they don't know or do our job. It's not like they have, we have to learn and be lifelong learners to figure out how to do this well. We can't expect a pediatrician to tell the orthodontist whether this patient needs expansion or not. I mean, to me, again, I think it's really sad. I heard they're revising it. I really hope that they clean some of that stuff up, because I know a lot of people who are kind of anti a lot of what we're talking about and anti involvement the orthodontist should have. There's there are orthodontists out there who say, hey, if you want to deal with airway, be a physician. And if you want to deal with this, there's a lot of that. And a lot of them, there's a lot of pearl clutching on that AAO 2019 white paper. And I think there's a real opportunity for the AAO to right that ship and take more of a stance like the ADA did. And that's maybe part of the reason the GPs and the pediatric dentists are kind of kicking our butts a little bit when it comes to the airway and the early treatment side of things. They are. I mean, I've had a bunch on my show. I talk to a lot of them. I have them reach out to me now that this is my what I do. I mean, I just had one reach out to me the other day, literally, and he's in New York City and told me he took this approach. He's a GP and orthos weren't doing it, and this is what he's doing now. So, I think we need to wake up a little bit as a profession, and the opportunity is so great. I'm not negative on it. I'm not pessimistic. I just feel we need to. We still have time, but that window's closing a little bit for us to really start to take our place at the top of this food chain when it comes to exactly what you said, having a whole patient approach when we see these patients.
Yeah, I'm optimistic. I really am. I feel like we can evolve, and I feel like we can evolve very quickly. I mean, for me, what happened is the dentist in the city in which I live and work begged me and
Mm.
other orthodontic colleagues to train ourselves up. And so we did. We took the challenge,
Good for
and
you.
I mean, it is a rabbit hole.
Yes.
But we care. We
Yeah.
care. Orthodontists care, and I want the best for patients. I would want the best for my own child.
Yep.
And that's really kind of the journey that I'm on, and I'm optimistic that we're getting there. Now, I know you have a unique approach to treating these interceptive cases. Can you kind of talk about what that is?
Yes. So when I started doing it, as I referenced, I used turnkey expanders, as most of us do for this. And I would put an upper Hyrax type turnkey and a lower. I started with like a Schwartz appliance, and as I talk about this, I'll touch on lower expansion too, because I know that's something that a lot of people still don't believe in. And I just tried a Schwartz appliance, which is a removable turnkey appliance, and it's just compliance was an issue, and kids would like turn it out of the mouth because they felt the pressure, and they try to like put it back in. They'd come in like, "Are you wearing it?" They're like, "Oh yeah, I'm wearing it." And no, so that was I worked with the lab I was working with at the time to use what's called a Williams expander, which is essentially like a fixed. It's like a lower holding arch with an expansion key in the middle with a Hyrax key is the way to think of it. And it worked. Those worked, and I got great expansion overall, but they didn't work as well as I would have liked them to, meaning all sorts of side effect and tipping of teeth, and you lose a primary tooth, and the permanent tooth is erupting under the bar, and impingement of the tissue on the palate, and ulceration and fissures in the tongue. The tongue doesn't have space, right? You take these kids who already are struggling with some speech issues maybe, and they have insufficient space for the tongue. You put these two big expanders in there, and they're, the parents would always say like, I can't understand them. They have marbles in their mouth. I had kids who wouldn't eat for like a week, and I literally would get calls. I mean, anybody who's done this has gotten the calls where the parents saying like, my child is not a heavy child. They've lost 7 pounds in the last week. Like, when is this going to stop? I mean, I literally would get calls like that. And so I always would explain to them, I know this isn't easy. I know this isn't, right now this is tough. It will get better. They will get used to it. And ultimately, this is a lot better because we're treating the etiology and not pulling teeth. But I always was trying to find a better way. And in the podcast with Lorraine, the interview with her, the webinar with Lorraine, I went into the details of how I got to that point. But being what it is, I got to the point where I started trying to do this with just braces and wires. And again, how things, you kind of come about things. But when I was talking to Tom Pitts yesterday, he said he has been doing this since 1979. And he is a wealth of knowledge on the literature. Wow. I mean, he trained by guys like Roth and Ricketts. Like, he literally like grew up with those guys in their arena. We just read about them. Maybe we're lucky enough to hear them speak or meet them. But he was in their arena, literally, figuratively and figuratively. So he figured this out long before I did, and has been doing this for many, many years. And the concept is that, I'll break it up into 2 parts. One, mandibular expansion. So a lot of orthodontists still don't believe you can or should expand the mandibular arch. Now, I want to be very clear. We're not talking about expanding the mandible. So when I teach on this or talk about it, a lot of people are like, Mike, the mandibular symphysis is fused around birth. You can't. I'm like, I know it would take distraction osteogenesis to expand the mandible. We're not talking about that. We're talking about someone whose mandible is a pretty good solid width, but they come in and they have a narrow maxilla, and quite possibly, and the patient will call this patient A, they don't have a posterior crossbite. Well, the only way you can have a narrow maxilla and not have a posterior crossbite, if you have a normal width mandible, is if the mandibular teeth are caved in lingually. It's the only way. So when I teach this, I talk about it like, let's take that as patient A, okay? Narrow upper jaw, narrow maxilla, the bone, and normal width mandible with a caved in lower arch, no posterior crossbite, crowding in the front and all that. But say this patient's like 7 years old. Then take patient B. Same exact maxilla, okay? Same exact maxilla, but same exact mandibular bone, but mandibular arch is not caved in. Those teeth are nice and upright over the bone, just like we're taught and like the ABO says they should be in the end, right? Level curve of Wilson, sufficient tongue space, centered over the bone. Not debatable that that's how the teeth should finish in an ideal case. We look at patient A, and I know for a fact, significant number of orthodontic residencies out there say, do not ever, there's no place to treat patient A. You do not treat a patient in phase 1 or young without a posterior crossbite. Yet, probably, I don't know this number, but I'm guessing somewhere around 99% of us were taught patient B with that posterior crossbite. And let's call it bilateral, right? Because if there's a shift, we get this sort of, well, they could grow asymmetric mandible. No, let's call it bilateral. They don't shift at all. They just have a bilateral posterior crossbite. We are expanding that patient's maxilla all day long. So what I say to people is, my contention is patient A, without the label of posterior crossbite, actually has a more severe malocclusion than patient B. Because in patient A, I got 2 arches I got to worry about.
Right.
Patient B, I just got the upper. Just expand the upper over the lower and call it a day. Straighten the incisors. That's an easy case. Patient B is different. And the thing is, Amy, we're not taught how to treat patient B. We're taught don't treat patient B. And so it's a fundamental mindset shift to say, okay, what do I do? Now, there are a lot of data out there to substantiate mandibular arch expansion. This has been being done, I mean, going back to the early Holzman in 1928, he had published a lot about this and talked about the need to, if you have deficiencies, exactly what I said, if you have patient A come in, he was talking about, it's 100 years ago almost, expand both arches to accommodate the permanent teeth. So we've been doing this for a while, but a lot of the most legitimate research comes out of the 60s with Schwartz and Gratzinger, and that's why it's a Schwartz plate. He was kind of the pioneer of this. This has been studied extensively since. And McNamara had a great article with Bichetti, Frankie, and O'Grady in 2006 in AJODO. They looked at this. They went in and looked over a long time period. I think it was 4 different time periods. They followed these patients, so well into retention. And they found that, I think the patient started at 9 years old. There were 23 patients treated, 16 untreated. And they found that the patients that had mandibular expansion, they used a Schwartz, and upper expansion ended up having superior results than just having upper expansion alone. So we know this. It's not, I mean, if you do it right. Now, a lot of people say, oh, you can't expand the mandibular arch. And a lot of those people will have no problem taking a lip bumper bow and cheat it out a little bit, right? They'll pull that.
The same thing. Yeah.
Same thing. I'm like, you're doing the same thing. Or they'll put a lower holding arch to try to save e-space. Before they put it in, they'll expand it a little bit, right?
Yeah.
You can't have it both ways. Like either you can expand on the lower arch or you can't. So I just take a little bit more proactive, and I guess you could call it aggressive approach, because I'm kind of going at it versus just putting a passive appliance with some expansion. Sort of a traditionally passive appliance, I'm actually putting fixed appliances in, or if you use a Schwartz expander, you're turning it. But the key is you're not turning it rapidly. You're turning it like once a week. So, and it's slow. So in that case, I was like, well, people hate these lower expanders. And I was pretty tired of all I dealt with. I mean, the bands on the 6s and the operculum grows over them. And it's just, again, I'm not saying it don't work. There's just a lot of challenges. And I was always pushing to be more efficient and have a better experience for my patients. So because of some circumstances that happened on patients who couldn't tolerate expanders, I just was like, well, I could try braces. And Amy, what started happening, I'm like, wait a minute, what? This can't be happening. This is this easy. These arches just started to develop with Broadwell arch forms. And then I had to get into figuring out what prescription brackets to use and how to, kind of level that curve of Wilson more. And I kept getting more advanced. But the concept is you can absolutely go in and expand mandibular arch in young kids to get those teeth over the bone. And when you do, and as McNamara's research proved, you get greater arch perimeter, and you get more space for the permanent teeth, and you have less incidence or need for extraction. So I then was like using that lower braces and an upper turnkey expander still. And then I started seeing some articles, or I actually went back, was looking in Profit and Contemporary Orthodontics with Profit and Fields. And Profit actually said that using rapid expansion or heavy forces, which I think it's Ladner and Mule had an article that talked about the exact forces. And it's like 3 to 10 pounds, I believe, of force for one turn of an RPE, where for like a slow type of expansion, like Ricketts did the studies with W arches and quad helices with L. Jaloy and 036 L. Jaloy, it's like 250 to like 400-ish grams, which I think it's 453 grams in a pound. So you're less than a pound, right? Half a pound to maybe a pound. So you're magnitudes of force less when you're talking about this. And Prophet said, using rapid, heavy forces in patients, you can go look it up in Contemporary Orthodontics. It's still in the most recent edition. He said that's excessive and can be dangerous and cause disfiguration of the facial bones. And I was starting to see cases where I was seeing that. I was like, their nose is like really wider than it should. Like the palate was widening out. And parents were saying it to me. They're like, Dr. Mike, like, we're really glad we're not taking teeth out. But like, is it normal that like her, nose looks weird or her face is changing? And when I do it with arch wires, you get reshaping and development of the face as it normalizes, but you don't get that like really wide look and the central diastema and all that. So there's a lot of drawbacks to that approach. So I just started turning the expander less frequently on top. Slow expansion, right? And then I was like, well, if I'm doing this, why am I using an expander at all? Like, why put this big bulky thing in there that collects food and makes them slur their words and drool and gag and all that? Because when you're putting these things on little kiddos, 6, 7 years old with not a lot of space in there, it's pretty.
It's a lot.
It's a lot. And they have more intense gag reflexes because of the glossopharyngeal nerve not migrating posteriorly yet. So again, it was a lot. They get through it, but it's a lot. So I'm like, well, let me just try with some braces. And it happened to be some kids with special needs who couldn't tolerate expanders. And then I started seeing that happen. And I'm like, this is crazy. And I started seeing how well these patients did with it. And I just pushed the envelope. And some wires, you need to expand them more. And some you can just use a broad arch form. The other amazing thing, Amy, is I found with expanders, turnkey, traditional Hyrax, even turned slowly, I would get, looking at an arch, it would take a narrow V. And I don't mean V in a vertical sense, top to bottom. I mean V like intra arch, and it would make it a wide V. So you would have these really wide sixes, and you'd have like, as you came forward to the C's, it would be narrow and tapered. And I know from studies, they show that the opposite happens with expanders. They're supposed to, you get more expansion anterior than posterior, but when it plays out clinically, it just doesn't always play out that way. A lot of times you get a lot, right? You get like a blown out posterior and you're still fighting for space for your canines when it comes time for phase 2. That went away because the arch forms are shaped totally differently, right? A broader arch form has way more space in the anterior and middle thirds. So you get tremendous arch form development on these patients. And the primary teeth are just the handles. They transmit the force to the bone. The other part of that is people say, well, you're not actually getting orthopedic change, right? You're not actually changing the bone. Well, Ricketts demonstrated you can have orthopedic change. There are tons of studies going back into the 1960s, 70s that showed histologic studies that you're getting orthopedic change. But where people kind of get a little twisted on this, and I totally get it because I was there too, is you're not getting like a midline diastema because it's slow. But Ricketts talked about that. You're getting and Melson has studies on this, looking at the histology of it. You're getting gradual remodeling of what is called, Melson had a study in 75 that talks about it's the juvenile suture. It's not the infantile suture, the juvenile's neck. So up to age like 10, she shows a really great coronal cross section, which shows that many of us have seen it. Once you kind of hear it, you'll kind of maybe recognize it. But it's this sort of cross section coronally where you see the midline suture, and it's a straight shot, right? Straight shot, patent. That's what you're dealing with. So when you transmit the force from the teeth to the bone, the palatal bone remodels. But no, you're not getting a big diastema, but you don't need one in this age patient. Now, from age 10 to 13, that's the juvenile suture, and that starts to be a little more of a tortuous path. Still not tremendously interdigitated and locked, but you start to get a little more interdigitation. And then when you get older than that, you have in the teen years, you have the adolescent suture, and that's a more tortuous path. And of course, as you get older, you need more force. You've got to be, and what you're talking about, then you get into needing, do you use skeletal fixed anchorage, right? I mean, it's all a continuum. And Jeremy Manueli and I had a great talk about, wouldn't it be great? He was on my podcast and he was like, wouldn't it be great when we can have AI look at a cone beam and be like, this patient, you can do arch wires, and this patient, so you need to turn twice a day. This patient once a day. And then this patient needs Marpy. So since we're not there yet, we just have to go off of the knowledge that we have. So people say all the time, a quad helix or a W arch can't get orthopedic change. That's false. I mean, the literature clearly shows you can. Are you getting splitting of the suture and this big diastema? No, that doesn't mean you're not getting orthopedic change. And I have the pre and post cone beams to show this in hundreds of cases. And we're working on trying to get some studies designed at NSU to try to analyze some of that data. But the point is Then I just took the last step to say, well, if I'm turning the RP slowly and I use the braces and wires, am I doing anything different than like Rick said with a quad helix in a sense? Like, I mean, quad helix, you could talk about the center of resistance in the high up in the palatal vault. If you've ever put a quad helix on a narrow 6-year-old, it ain't that high up in the palatal vault. I can assure you that. It is almost flat. I mean, that sucker is like, it is tough to get that thing up high in the vault. And they just have logistical challenges, right? Reactivating them intraorally is hard. So titrating the amount of expansion, and I just found them cumbersome. So braces and wires it was, and the patients love it. It's easy, it's efficient. It makes phase one, and I know it's a bad word to talk about with this, but we're all running businesses. It makes phase one profitable. I wasn't, and I think that's part of the reason people shy away from it is a couple of reasons. It's hard to do. We're not really, like I said, hard to do. We're not really trained. It's no fun cramming upper and lower expanders in 6-7-year-old mouths, little mouths. The tears, the parents coming in the back, flipping out, trying to turn this thing, and the kid gagging. I mean, I've seen it all. I did thousands of cases that way. It's not a lot of fun. And then the last part is it's hard to monetize because there's so many visits and these appliances are expensive, and the banding and the number of times you have to have that patient in to check and extra care visits and everything. When I went to braces and wires, it's that patient I was referencing a little bit on the podcast that I was telling the residents about yesterday with dad's the certified registered nurse anesthetist. It was 7 visits, and she ended up being over COVID. So it kind of lapsed a little longer, but it was a bond. There was 4 adjustments. There was 1 progress bond to bond her laterals when they came in, and her debond. No SEPs, no bands, no anything. Like nothing. I mean, it's so easy. The kids love it. I interviewed her. She's like, I love the braces. I mean, the kids love it. And that's why I'm so passionate about that. So my real passion is the first part of what we started talking about, which is get these kids early and young. I love what you said about a whole patient approach and starting to take more of a broader perspective of how we approach these cases. And as long as people are getting in there young and helping these patients move, whether it's with expanders or Invisalign first or braces and wires, it really isn't as big of a deal to me. Just get in there and start addressing these deficient arches young. But I will say I found that it transformed my practice from an efficiency standpoint, chair time, financially, patient comfort, raving fans. I mean, we would get people that would literally just call us and be like, we're an hour away, but we know Dr. Mike's the only one that can do this without expanders because we've seen so-and-so and so-and-so, and we're driving. So, as far as from a practice management standpoint, I never advertised it. I never put it out there like expanderless expand. Never. I mean, I never advertised airway orthodontics. I never advertised I can help breathe. Never. But you don't have to, because once you start helping enough patients who see what you can do, they do the advertising. They tell everybody it was more business than I could literally handle. I mean, it got to the point where phase 1 started getting such an impact in my practice that it was I have a room for these patients at this point, because my other phase 2 and adult volume was still consistent and chugging along. And then all of a sudden you take your phase 1 and just exploded. So
yes.
Yeah.
Well, you're naturally creating these raving fans,
Right.
And on the other end of the spectrum, which is where I am right now, is these custom Marpies are a beast. They are a beast. I mean, it's helping adults, but it's a lot. And
how do they tolerate them overall?
Every patient is different. I've had one female patient describe it as having birth in the mouth.
Really?
Which is a terrible analogy, but
is it worse as they get older? I mean, obviously I know like the teen years, but like, is it like 40s are way worse than 30s or way worse than 20s? Or
I mean, the harder it is to split, the more difficult it is, because there's just more pressure to actually get the split. And so my point is, if we're doing interceptive treatment on the front end, the goal would be to avoid these patients needing that therapy on the other end, right?
Great point.
So looking at whole health and really trying to help these patients proactively is where it's at. And that's, again, what I would want for my family member, from my husband, who I don't want snoring, to my children. So I think it's really important. And you, my friend, are just a wealth of information. So I really appreciate you hopping on here today and giving us just a few nuggets of what's inside your brain and things that you're doing to help patients and help orthodontists. And I'm really so thankful that our paths crossed, and
Me too.
I want to continue the conversation because I think what you're doing is you're continuing to evolve, which means you can bring better and newer information to all of us who are busy practitioners who
Yes.
want to provide an excellent service for our patients, want them to live their best life and their healthiest life,
Yep.
but sometimes don't have the time or the bandwidth to comb through
Mm.
the literature and get up to speed on everything that is happening in the moment that it's happening. So
Yep.
what you're providing is really, really so valuable, and I just appreciate you. Okay.
I appreciate that so much. And I really, as I said, I've enjoyed working with you and your team. You guys are awesome. And thank you for giving me the opportunity to explain this. I'm used to being on the other side of the microphone, so to speak. So it's really nice to be able to talk about this as my passion. When I have a guest, you don't want to be, taking my stance and my side too much. So I really appreciate you giving me an opportunity to explain my side from this angle.
Yeah, I appreciate you. And as a retention company, I would love to hear your thoughts on what worked for you. Again, you've been through an evolution, so I would love to hear what is working for you now as far as retention for these interceptive patients specifically.
Yep.
And then the second part of that question will be, do you believe it is stable long term?
Yes. So excellent questions. The first of the retention that I do, I actually just use clear upper and lower retainers, Essex type retainers. That's it. It's literally, we used an Essex C+, like you just cut them out as the teeth grow in. You see them full-time 3 months, nights only. After that, see them every 6 months for their growth retention checks. And it's kids wear them. They're comfortable, especially if you have 3D printing. That's a huge, our compliance and our results of retention improved so much once I went to 3D printing and had my own 3D print lab in my practice, in my office and the lab, because that makes the fit so accurate. Obviously have a nice strong vacuum form and be able to have a positive pressure vacuum form to make sure it goes into the vault of the palate and the height of the palate. So if you do that, it's easy. The kids wear them. They're compliant. Now, what does it look like long term? So I had a couple articles last year in OrthoTown, and the second one, which I believe was in November, was talking about the retention that I see and the stability. And what that is amazing. I had so many patients after I started doing it this way who didn't need phase 2. And one of the things I get frustrated with is some of our colleagues will say, well, don't, get the teeth too straight in phase 1 because they won't need phase 2. My attitude is just get more done in phase 1 and charge appropriately for it. Instead of undercharging for phase 1 and not having any revenue and needing them to do phase 2, just reverse that mindset. And then what you can do is watch them grow. And some kids, the teeth come in beautifully and they don't need it. And we just say, hey, we're going to make you a set of final upper and lower retainers. We charge for that. And you're going to wear these nights only for life, or use a company like Retainers for Life to assist you with that process. Would be a great opportunity to do that. And then if they did need phase 2, it's a slam dunk. I mean, you're talking about some tooth alignment, maybe a little AP, maybe a little endon class 2. Some patients, were retrognathic and you put a Herbst on, but for the most part, your transverse is fixed, your vertical's fixed, you fixed the arch form. All of that's been fixed in phase 1. All the things that give us the biggest headache in phase 2 or comprehensive treatment, if we don't do a phase 1, I should say, that give us the biggest headache in comprehensive treatment are solved by what you built in phase 1. So you just go in and it's predictable. It's easy. A lot of time you can use clear aligners for that. And the parents get it. The key is you explain to them in the beginning, expect 2 phases. Expect that they will need it to be done, one thing now to address now's problem. And then we might have to do some alignment and fixing and perfecting the bite once all the adult teeth come in. And as long as you're scripting your TCs properly and you understand that philosophy and your team understands it, you relay that to the patients, and it's pretty self-explanatory. So that would be how I would say, is the overall approaching the retention and the stability side of doing that.
Hey guys, I just wanted to jump back in and say thank you so much to Dr. Jackson and Dr. DeLuke. If you would like to learn more about Dr. DeLuke's company, The Ortho Coach, you can go to theorthocoach.com. Thanks, guys. Appreciate you all.